I have the pleasure to introduce our last speaker for today's sessions, and welcome Michael Paasche-Orlow.
This is actually a talk that I've never given before. They said, hey, talk about implementing health literacy initiatives. So I'm hoping that in this session, we're going to start off, I'm going to look to try to stretch you guys a little bit. And by that I mean, so when I say stretch, what does stretch mean to you? Stretch like this? Okay, what else does stretch mean? What else could it mean?
Reach for something. Yeah.
Reach for something. Okay, that's stretching. You actually could reach for something, try something new, yes? Challenge yourself, that's right. And I also want to give you the opportunity to kvetch. Who knows what to kvetch is? Oh, yeah, to complain. Yes, what else? Complain. So this is, we're going to start with stretch and kvetch. Everybody stand up, stand up. Stretch and kvetch. So to stretch, you actually have to stretch. Imagine I have a huge beach ball, and I'm going to throw it to somebody, and then you can say something that you're complaining about, something that makes it hard for you to implement stuff. Who here has been involved with trying to implement stuff in health literacy? Okay, I'm going to throw. You have a kvetch? Can I throw you the ball? Okay, oh, that felt good. Okay, you got it. Now, when you throw it back, you have to complain about something.
I hate it.
What's that?
I hate it.
You hate it. Oh my gosh. I hate it.
I hate going to work for health literacy.
Oh my gosh. Who else has a kvetch? I did this once with my grandmother and her friends, and we had a circle stretch and kvetch, and they said, they never write. You know, okay, so I told you he was no good for you. Okay, here you go. There you go. What do you have for me?
Publicly posting the charge master.
Oh, posting the charge. Why? Anybody else? Ready? Here you go.
Federal government regulations.
Federal government regulations. Okay, I think there's anybody else. I got here. There you go.
People that say we can't.
All right, people who say we can't. Maybe a kvetch over here. Anybody? I think you put. Oh, over there. That's for you. That's for you. You said, what does kvetch mean? Now you get to kvetch.
Wanting to do something really big with no partners for free.
Oh my gosh, they always say that. Okay, everybody sit down. Everybody sit down. In order to do implementation work, I mean, there's a lot of challenges, but I'm actually going to start back farther than that, because actually I want people to think about this from the beginning of what problem they're focusing on. There's a problem, you have to develop a strategy, then you're going to have to try to implement something to improve that. You should evaluate this and then hopefully improve. We're not going to get through everything here, and hopefully we're going to focus enough of our time on implementation. However, I want to start back on the problem, because you're not going to solve every problem. Unfortunately, we're probably not going to solve all of the government stuff today. Not today. There are several problems identified here. Some of them you can solve, not all of them. Okay, so let's go. Choosing a problem. There are many, many problems in health literacy. And oftentimes what happens is it starts with observational research, right? And we observe things. But also we have to observe ourselves and think, what are our priorities? What is our priority as an organization? What are our priorities as an institution in terms of what we can do with the nature of our organization? We come from very different types of organizations, right? And so you have to figure out what the priorities are, where there are opportunities, where there are going to be resources, and then you have to think about how you observe and understand the nature of that problem. And there's many, many types of problems. However, I need to encourage you, choose substantive problems. Don't just nibble at the edges. This is our Hops, our bunny Hops died last year. Hops was fantastic at nibbling at the edges. If you're going to nibble at the edges, just keep on going until you get to the core of it. Because, in fact, you should take on substantive problems, okay? Oftentimes people ask me about how do you measure health literacy. This is just a random plug for our website. Yeah? Okay, there you go, see? And anybody know how many tools we have on the website now for measuring health literacy? Over 175. So there's if you want to measure this concept, this is a resource for you. All right. There are a lot of problems. Health literacy has been identified as a problem in all these places and in many, many more places. But that's not just enough. That's not going to help you figure out what to do. Effectively, when you think about health literacy problems, the observational researchers have done stuff like this. And this is a very important, very influential paper. It's now over a decade old, but this is a very influential paper. This showed that you know, health literacy, everybody who came into this study was 66 years old. Over 3,500 people in this study, and they observed folks over the course of 80 months, and they saw that health literacy was associated with over a 50% chance of, adjusted chance of dying within the time of the observation. And this study, they adjusted for income, insurance, BMI, smoking, diabetes, blood pressure. Like they adjusted for a lot. They were looking for what is the independent effect of health literacy for this outcome. It's about one of the best papers in this space, okay? But ultimately, even an observation like that, even a very, very well-funded and well-designed study, doesn't get you so far. Okay, who sees the observation? We need observationalists too. Without observationalists, we can't really do implementation. We won't know where to focus. Who knows what's lurking in this picture? Anybody see anything? Okay, some people see it. Okay, you need observationalists to work this out, right? You see the deer? Okay, that's the easiest one. Gets harder from here. We need observationalists. Without them, we won't find the problems. Is there any problem in this picture? Anything lurking here? Call it out when you see it. Yeah, there's a wolf there. Oh, cool. Right there. Okay, there are dangers lurking. And you need to actually find them. It's not so easy to find. You need observationalists. It's not all going to be done by implementation scientists. If you're an implementation scientist and you don't work on a team with observationalists, you're going to be a bull in a china shop. You will, because you're going to go in there, you're going to say, I have this cool thing we're going to do, blah, 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 blah. And then people will be like, did it help? Did it work? Did you help people? No, maybe not. Anyway, so I'm very strong on team science, on interdisciplinary teams, and having people together. This was a bunch of scary pictures to talk about that. Okay. But there's another part of observational research that's also critically important, which is to figure out how do things work together. What is the causal pathway? How is it that someone with low health literacy will end up with this worse health outcome? What's the causal connection? What's the linkage? So here on the next slide is my simplified model. Excellent. That was the fastest laugh. And who laughed first? Someone over here was fastest laugh. Fantastic. Oh, there you go. All right. See. So it's important to do this kind of stuff, to think about what are the causal connections, because in fact the interventions will look very, very different depending on how things work. So for example, if your challenge is vision or hearing, if that's your challenge, if your challenge is memory, the intervention is completely different, right? It turns out that there's a whole group of people who don't have adequate vision and don't tell you about that. Not everybody actually even has insight about that. But the intervention is completely different. What's the leading cause of vision so bad that you cannot read at 2200? You know, functionally blind. What's the leading cause of functional blindness in the United States? What was it? Diabetes is one vote. Any other votes? Cataracts? What? Macular degeneration? So you're all wrong. It turns out that the leading cause in the United States for functional blindness is not having glasses, is lack of refraction. We actually have a fantastic, fantastic country, but we have lots of people who don't have glasses, right? The intervention is completely different. That's a different intervention. As it turns out, in every state in the country, if you're functionally blind, the state will pay for your cataract surgery. And that's a fantastic opportunity to but that's a very different intervention, right? If the challenge is language, if the barrier is language, you have to learn how to provide language concordant services, language appropriate services. That's a different intervention. So let me put all this stuff aside and focus a little bit on this, because I think this is going to be a little bit more in the space where at least some of you are going to be thinking about for implementation directly related to health literacy. And this model there's several things about this model that I want you to appreciate, besides the fact that I have some advanced PowerPoint skills. Changing colors. Okay, so there's several things about this model that I think is very important. Anything somebody says to you on this side of the model, you should also think about this side. If someone says to you, I'm here to improve self-efficacy for patients, fantastic, fantastic, we should do it. But there's also the other side. The providers also have whatever level of self-efficacy they have for communication, and is often weak, right? So don't just blame the patients. Anything you say on one side, think about what's the other side. If you say, we have big access issues, how patients get into the system, how they access and utilize care, well, you also have to look at the other side. Why is it so complicated? Why is it that the doctor's offices aren't even open? Oh, you can go around and wag your finger as much as you want for patients going to the emergency room at night or in the weekend when they take their kids to the emergency room, but in fact, that's when they can. Like that's, if their jobs don't allow it or the clinics aren't open, that's what they're doing. So anything you say about a patient, say about the system. Anything you say about just, if you're on the left, also on the right. Both of these, I think, are relevant. And part of this is to think about when you're doing interventions, think about all of the different perspectives on that problem that you're focusing on. And then it's about developing a strategy. So ultimately, I want you to then think about this. What is this? Yeah, but where is this? Some people must, that's LA, this is LA, this is LA. This is LA every day. Why am I putting this up? This slide is to say, what recommends a lot of the observational research, at least the observational research that was done well, is that they looked for the independent phenomenon about health literacy. However, those regression models don't go far enough. Because a person, you're going to go back and intervene with a person. A person is not a regression model. Very, very frequently, vulnerabilities can run together. You can't just magically go to a person and say, I'm now going to interact with you on this aspect of you over here. A person is a person, and they have whatever vulnerabilities they have. An organization serves a population that has whatever vulnerabilities they have. You cannot just magically imagine you're only going to interact with people in this very specific way. A person is not a regression model. And when you go to do interventions in your organization, you cannot imagine that you're only doing magically one thing. You have to actually think about it a little more broadly. So when you think about this, I think it's good to have a broad perspective of who the stakeholders are and to make sure that you bring all of them in. Ultimately, there's a lot of things you can do with stakeholders that will be important, not just in understanding the nature of your strategy, but also in implementing your strategy. You can get them together on your team for it. And eventually, the best thing is to co-create the strategy with the stakeholders. And it really depends on ultimately the nature of your goals. Oftentimes, health literacy interventions come down to things like this. Are you talking about information transfer, improving that? Talking about skills, empowerment, attitudes, or behaviors? And all of these things, in any kind of context, will have the nature and range of the stakeholders that are relevant. And if you're only dealing with one subgroup of that, you often don't understand the nature of the problem. Here's a bunch of challenges. Something gets published someplace and you want to figure out, like, can I bring that into my institution or my organization? And there's a bunch of things. Here's a few things to call out. One of them is that some people say, okay, I'm going to create an easier to use version of some process. And then we have a harder to use and an easier to use. I've never understood this approach. This is very common to see. I think that if it's going to be better, it'll be better for everybody. If you make it simple, if you make it easier to use, it'll raise all the ships. It turns out that if simpler, straightforward, clear communication actually is better for educated people too. Is better for empowered people too. It turns out the retention of information is better for people if it's a clear communication, if you simplify. So I don't go with this tailored approach. I usually go with simplified. Personalized is super important in a lot of contexts, but sometimes it's outside the opportunities that you have. As much as you can personalize, I can show you examples of this. That's better. Multiple channels is frequently important. It turns out that we frequently interact with people when they're not at their best, they're not feeling so great, and you're going to have to figure out multiple channels, multiple opportunities, and repeated channels to support whatever work you're doing. It's not this like magically you do one thing and then it's done. So how many people know the Reamp framework? Anybody hear the Reamp? Some people in the back, some people. So I put this up and I'm going to put a slide or two about Reamp because from the beginning of designing your strategy and thinking about it, you have to be thinking about the implementation. I'm going to focus soon, I'm going to shift really on implementation. But if you don't think about it from the beginning, you know, you can have all kinds of challenges. Shocker. No, we can't do this in our organization. Shocker, this actually costs money, or this needs personnel, or it should be like, you know, oh my gosh, that takes training. And, you know, so from the beginning, you have to have Reamp. Reamp, what's this? Reach. How do I reach the targeted population with this intervention? So when you design a strategy, if this is not already on your mind, you're basically going to shoot yourself in the foot. How do I know if my intervention is effective? That's usually the domain of an efficacy trial, of an effectiveness trial. I'm sorry, an effectiveness trial. That's usually the stuff that usually gets published in the research article, but usually doesn't go far enough. Usually you read a research article, you don't know how to actually implement anything. You just say, oh, and some assertive people will go and contact those authors, but you know, sometimes they're on to the next thing, and you know, oftentimes they don't even know how it worked. That's another conversation. Adoption. How do I develop organizational support to deliver the intervention? And this is a lot about, you know, how to have power in an organization and stuff like that. But if you're not thinking about adoption issues from the beginning, it shouldn't be a shock that this can be challenging. Implementation, how do I ensure that it's going to actually be delivered properly? And maintenance, how do I incorporate the intervention into the culture of the organization, into the culture, the fabric of the experience, so that it actually will happen long term. So I actually have tried hard to include implementation science people in the interdisciplinary team from the beginning. So when I say, you know, team science, and I'm talking about like having an interdisciplinary team, that includes people whose job it will be down the road is to be implementing, you know, leading the implementation. They should be part of it, the design from the beginning, so they can say, you know, I don't think people will be able to do that. Even if you think it's going to be effective, you prove it's effective, no one's going to do that, you know, so what? So you get a journal article about it. About 15 years ago, I started working on the problem of readmissions. Now it's a, you know, so people discharge from the hospital and come back to the hospital too soon, and in unneeded ways. And this whole thing ended up becoming a very, very large national priority. Because if you imagine, you know, people don't really want to be back in the hospital, and it costs a lot of money, and it's a big pain for everybody involved, and if it's not needed, then it'd be good to avoid it. It became a national target prioritization topic for around the whole country. And let me say it like this. If I sold used cars, and 1 out of 5 cars came back on the lot within 30 days, you'd say, I'm selling lemons. And in every state, there's a lemon law for cars to come back. If you come anywhere close to that, you get closed down and you can't sell used cars. But 1 out of 5 patients come back on the lot, back into the hospital within 30 days. Think about it. That's not a great product. So we started thinking about how to improve this as a product, as a process. And we went through a bunch of different approaches for observational research. We did probabilistic risk assessment. We did process mapping, failure modes assessment, qualitative mapping. We did root cause analysis. And you know, we try to say, what is this process and how could we reorganize it? We brought together a ton of stakeholders. And we came up, this is a picture of one little small part of the process map. Has anybody here been involved with process mapping? Some people. Okay, so was it any good? Or was it a pain? It was a pain? Was it useful? Ultimately? To identify the gaps? Yeah. Yes, it was useful? Okay. So if you don't know about it, most people in the room haven't been involved with this concept, but I think it's very, very important to think about and to maybe bring people in who can help you with this if this is relevant to the problems you're looking at. One of the things that I learned a lot when we went to go and do implementation in other institutions is that oftentimes, the notion that leadership would have about how processes worked in their hospital very, very poorly reflected what actually was happening in the hospital, that there was a massive gap. So when I'm talking about process mapping, I'm not talking about like some ideal state, but like the real state of affairs. If you have a sense of the way the process is going, then you have a chance, at least a running chance, of reorganizing it. it's useful to know how things work in order to break them and make them work better. And you really do need to break them in order to make things better, because there's a lot of people invested in connected to the different parts of how things are, and you're going to ask them, you're going to move their cheese, you're going to ask them to change how they behave. And so you have to understand who's involved and what they do. We came up with this concept called the RED checklist, the re-engineered discharge, and it had all these things in it. And a month later, the National Quality Forum adopted it as a safe practice. Is that good? No, that's ridiculous. We had no evidence behind it. It's like ridiculous. Like, what were they thinking? And they make everybody say, oh, this is now. Anyway, so we said, no, you can't just do that. So we did a trial. And ultimately, all these things, like how are you going to operationalize them? This is what we did to operationalize them. We created a patient-facing concept called an after-hospital care plan. It used to be called the discharge plan, but some guy asked me in a focus group where the discharge was coming from. Actually, to be honest, that was like the third focus group already, and I think other people probably thought that, just weren't like able to say that out loud. Anyway, so we created this thing, after hospital care plan. We created a new role in the hospital we called the discharge educator, which was a nurse whose job was actually to make sure all these things would happen and to actually take the after hospital care, take it to the bedside and to do it. You know, there's a ton of garbage that's currently in your discharge plans, and no one ever cares because they don't actually go to teach anything. And so, so if there are medications on the list that the person doesn't take, like, who cares? Because they don't. It's just a bunch of garbage. Anyway, we also followed people up with a phone call with a clinical pharmacist 3 days later. Anyway, so this is kind of what it would look like. It's personalized. It has your medications in a kind of a simplified heuristic how we developed it. It has appointments. It goes to a calendar. Blah blah blah. I don't want to really focus on Project Red so much, but I want to get to the thing, we did a trial, and it was a massive success. It decreased coming back to the hospital by 1/3, which is a tremendous amount of money. This is a very, very small thing. Okay, I jumped all the way ahead. So what do I want to tell you? Why am I telling you about this? Because we were then, AHRQ, who funded this work, they said, great, implement it around the country. And they funded us, and they funded others, and ultimately over 500 hospitals got training in Project Red. Most of them failed. Most of them did not succeed in doing this. And so I have some lessons that I feel are to hear and to learn about challenges with implementation from this experience, from actually a lot of experiences. We created learning networks in several states of groups of hospitals to do this stuff, and most of them did not succeed. Some of them did and are still doing it, but fine. This is one of the problems. Anybody have one of these? The Ronco chicken rotisserie machine? I always wanted to have one when I was a kid. Did anybody has it? Yeah? Oh, it's fantastic. You set it and forget it. You put the chickens in there, and then they rotate around. You come back and you have like dinner, right? It's fantastic. Okay, so this was effectively like the model in the minds of many of the hospitals where we went. They were like, oh yeah, you'll come, you'll do grand rounds. You're going to talk to the people. You'll do a training with the nurses. Set it and forget it. Like as if you could have like a training and then you would do all this stuff for the rest of time. That is outrageously ridiculous. And if changing organization is hard. The work of doing change is a lot of work. You actually can't be like this guy. Maricel said to me, who cooks with a tie anyway? That's clearly not real. That's weird. Anyway, this is how you have to be. You have to guard your implementation like a hawk. You can't set it and forget it. I took this picture right outside my office. I saw this hawk take this pigeon down, and I went over to this hawk, and he was like, get your own damn pigeon. This is my pigeon. You have to guard your work like a hawk. If you want something to actually happen, you have to stay with it. You can't just walk away. I taught the nurses how to. That's ridiculous. That's not how it works. That's not how organizations change. So this is one of the things that happened. Oh, you'll come and do ground rounds. We'll do Project Red. Ridiculous. You have to figure out how to align your project with the goals and vision and plan of the organization. There has to be alignment. And you have to learn where all the power sits. It's actually not enough to just have a powerful executive sponsor. You actually won't get anywhere without that, but that's not even enough. You have to find all the other sources of power. Part of what the process map does is helps you design so you actually can interact with people. I would ask hospitals to do a process map of their discharge process before I come in and do training with them. And they frequently would show me a process map that was completely anemic, completely weak. It wasn't real. And I said, oh, who developed this with you? And they were like, oh, we sat and did it. I was like, no, did you talk to the social workers? No, why should we talk to them? Did you talk to the discharge planners? Yeah, they were. Did you talk to the clerk? You have to talk to everybody. You have to figure out where the power is and where all of the parts of it are and how to figure out how to do something. You have to align yourself. So like, for example, in my hospital, before we even started, the executive sponsors, they said, this is fantastic, but don't talk to the union. I was like, what are you talking about? We're not doing anything without talking to you. This is like, you have to find out where if your intervention threatens anybody's job, they will find a way to ruin it. Your work has to align with the goals of everybody. If someone feels threatened by your work, they will find a way to, one way or the other. The slow, passive-aggressive death is one of the worst deaths. It's really one of the worst deaths. You have to find your way to align your stuff with everybody's vision. And in the discharge space, it was quite difficult. You know, most of the concepts, most of the perspective of hospital admission is about hospital admissions. Who's up for the next admission? Who's getting the next admission? Who's getting the next hit? We wanted people to be proud of their work product when people were leaving. That's like a new orientation. That's like a whole new perspective. And if it threatens someone's job, it's just not going to get done. So this is about alignment. There's a whole bunch of stuff to talk about for communication issues. When you ask people who's on the team, it's very important. Also find out who's not on the team and what's buried in that. So if they tell me the union is not on the team, why are you doing that? Like, what's going on here? Is there some reason for that? Anyway, who is on the team, and is there some reason why someone would not be on the team? Anything you want to do, there needs to be a mechanism to know if it's actually happening. Okay, so evaluation and feedback supervision, you know, this is a basic bread and butter QI. If you don't care, don't measure. But if you want something to actually happen, you're going to have to see that it happened. This is true. This is true and true for everything. Like, you know, the teach-back method. If you don't care if the patient doesn't know how to take your medicine that you're offering them, fine. But if you want them to actually take it, you're going to have to check that they understood you. That's the teach-back. Here is the same thing. If you want to know that the staff is doing teach-back, you're going to have some mechanism to check if they're doing that. And part of this is really having a culture of change, an opportunity and culture. And so what does success look like in this organization? What kind of changes has this organization succeeded in making? Have they always failed when they try to make change? Or when they do succeed with change, what does that look like? Who was involved? How did it work? What kind of meetings had to happen? So this is part of like getting, you know, a little bit getting to know you, but also, you know, is there a culture here? And if there's not, how to walk back and say, okay, are we ready to create that culture? I mentioned before a method, root cause analyses. Anybody use root cause analyses in any of their work? Some people. There's a few recidivist hand raisers. I think that means something about what part of the world you've been involved with. Root cause analyses and process. Yeah. So root cause analyses, if you could find a way that the mechanisms for organizational change in whatever organization you're in, if they can be aligned with your work, then you have a chance. Right? So if you're an organization that has a QI mechanism, have them be part of you. Have you be part of them. So we created I went to a series of organizations that basically had never really considered issues relating to readmissions, and this particular group totally wasn't ready for it. And they heard me complain about this phenomenon in the past. So they said, we want to start by we agree. We have to start by creating our QI culture here. We started by having monthly root cause analyses meetings for instances when people were readmitted. They had never done that before. It's just kind of like how to take the mechanisms of change and to get them involved with what we were doing. And by doing this, over the course of a year, we created enough of an alliance to actually do the next step, which was actually the intervention. This was actually in a network of nursing homes, and it had a fantastic, but it took a whole year of pre-work to kind of help create this network of nursing homes did not yet have a QI culture, did not have people identified to do that, and we grew it. Almost everything you do, you should have another hat on, which is marketing. People in marketing? Anybody? Yes. So this is like you think that you're doing your project, you're actually also involved in the marketing of your project. And if you have any kind of complex organization, that's totally part of it. Okay, you did this thing. Okay, fine, but our people work here in 3 shifts over the course of a day. And you did this thing, but we have all these people who work in this other part of the organization. So how do you communicate all this stuff? And part of it is marketing. Having the power. It is crucial to have enough power. In fact, by the time we were done going around the country with the red stuff, our implementation group basically said, we will not come to visit you if you do not have an executive sponsor who gives you the time of day. I once went to a network of hospitals that were trying to do implementation of Project Red, and the first part of the day they had the executive sponsors in the room, and then they all left. They all left. And before they left, I walked up to each person kind of like in a break, and I said, I want you to tell me the name of 3 people on your team that's coming in for your training all day today. They couldn't name anybody on the teams because they were not really actually invested. They were not actually engaged, right? Or I'll give you another example. I once did another hospital. I went there, and we had this, the executive sponsor came in, and he's nice. We're having a nice thing. And then he got up, he said, I have another meeting to go to. I'll see you guys at lunch. And I said, what are you going to? He said, we have this other program working on reducing mortality. So I said, hey, why don't we do this together? He said, no, it's a different problem. Readmissions, different problem than mortality. See ya. So I put $5 on the table, and I said, where's that meeting? He said, it's down the hallway. I put $5 on the table when he left, and I said, I guarantee he's going to leave that meeting in 15 minutes. We're going to be waiting for him in the hallway. So he did. He went down. He did the same thing in that other room. He said, hi, see you, bye. And then he left that room, and then we were there lurking in the hallway. Anyway, you have to have the power. You have to have power. If you don't have power, it's almost like a waste of time. I'll give you an example. Another hospital we went to, there was a series of readmissions that when you looked at them, when we did a little bit of RCA work, very, very easy, we saw that there was a cluster of readmissions for a particular oncologist. And when I asked the project team to go and talk to the guy and to find out what was going on, because these were patients who were coming back to the hospital a lot and for avoidable things, I said, go and talk to the guy and find out what's going on. And they said, we can't talk to that guy. He won't give us the time of day. What we need to do is we need to go up the nursing chain, across to the medical chain, and then down the medical chain, and our sponsor says that they can't do that, to talk from his supervisor down to him. So I said, I don't care. I'm not from your organization. So I called the guy up, and we were talking. It turned out he had a bit of a crisis he had a bit of his own personal crisis, and he decided, he didn't tell anybody, he decided that he no longer believed in hospice. He didn't tell anybody. So his patients, he would send them home, and when they got into trouble, they would come back, and he just decided it wasn't his thing. And so, in fact, that's not part of the organization's mission and vision. And so we had to go and get an executive sponsor who would come in like a predator drone and drop bombs from a different direction. Because you have to have power. If you don't have enough power, it's awfully frustrating. Like the project team was like, he won't even talk to us. And it was his personal little thing. And you need to have enough power. So I just recommend that if you're doing something and you're finding yourself not having enough power, don't just spin your wheels. Go and get the power. Do stuff that you have the power to do. It's too frustrating. Life's too short. We also saw a tremendous ton and a half of bad project management. There's just so much that could be said about this, but it's super generic, so I'm gonna move on. But there is a ton of bad project management. So if you're the one who has to be accountable, you actually have to be accountable. We had so much bad project management, we basically said, we're going to engage you with your hospital, but only if you fill in these milestones documents for us every month and send them to us. And if you can't even fill these things out, we're not going to be coming to visit you because you're not even doing grade student work on your project, and we have to come and help. It's not going to work. Project management is super key. And if you're supervising the project managers, understand what they're doing, get involved in their life, and see that they're actually doing it. There's a ton of bad project management. Design things for a role, not a person. It happens on a regular basis that people would say, this is great, but then it didn't work. Well, okay, your project needs to work even if Cheryl's sick. You have to design things for roles in institutions, not for people. If it only works because you have this fantastic one person and if that person's gone, the whole thing will fall apart. You're not going to make substantive long-term change. People would frequently say to us, do you want us to do this for everybody? We only want to do it for a small group of people. We don't have the resources. So you have to decide, are you going to do whatever intervention for a subgroup or for the whole? Are you looking to make change for the whole target population, or are you going to look only for a subgroup? These are decisions to make. I found this a lot. People are too polite to bad acting managers. You want to make change, you align yourself with the values, you say, are we in agreement about these things? And then if they're blowing you off, you just got to call it. You got to say what's going on. In our context, this happened quite a lot. People are too polite. People frequently avoid talking about money, even though it's frequently relevant. People avoid talking about psychiatric problems, even though it's frequently relevant. And there's all kinds of other things. So, depending on the nature of your organization, just find a way to, sometimes you have to manage up to find a way. And it's not always polite, but sometimes it's important. We created our model with a dedicated nurse, a discharge advocate, but in order for this to work in the range of organizations where we were going, we needed the model to be flexible. And depending on the types of change you're looking to do, sometimes it requires being flexible. We can talk about that more. And this is other types of problems that also often frequently interacted. So as opiate crisis came into Boston, we had to adapt. As housing insecurity became more and more relevant in our institution, we had to adapt. Another thing that happens is if you're working well, people are going to use your brand to raise their ships. And so you just have to figure out if that's going to work for you. I'm a big tent guy. If this is going to help, let's go. Come on, let's go. I'm going to switch gears to a totally different intervention model, totally different project. But I think there's some other things, other lessons learned about implementation. We have a series of projects relating to short video decision tools that we create for advanced care planning. And we've done a lot of work in this space. These are 4 or 5 minutes long, and we want patients and providers to sit together to watch them and then talk. It's like a health literacy intervention oriented towards advanced care planning. And we do to improve decision making. So we've shown in a whole series of projects, over 12 RCTs now, that this improves knowledge, it improves decision certainty, it improves stability of preferences over time. We've shown that people think that this is very, very well accepted. Okay, so then we moved into implementation. In order to implement this stuff, a few slides about outcomes. I'll just skip this. It worked in a lot of places. Woo. Woo. Okay, so in order to do this, to make it work, we actually created, for implementation and for the next steps, we created a foundation. And in the Advanced Care Planning Decisions Foundation, we have a whole video library of categories, and we've expanded on different languages, so it's like growing and growing and growing. But how do you go from here to being in 600 hospitals and clinics, which is where we are now? Okay, so it's expanding. But it took a lot to do that. Some lessons learned. In this instance, it's a very different type of intervention. we had to learn a little bit better than in the prior project about how to respect the organizational culture. Each organization where we were going effectively had its own microcosm, its own kind of climate, and its own approach. And frequently people, well, they may or may not be in touch with it, right? So we wanted patients to sit with providers to watch a 4-minute video and then talk about their wishes, patients with advanced illnesses. We often start with cancer, but we go on to other topics, right? Some institutions, they'll say, only the doctors can do this. And some of those institutions, we have to respect that because they're not going to change off of that. But usually that's actually not going to work. Usually that's not going to work. So for example, we did a project with Kaiser Northern California, and they said, doctors have to do this. And we said, you know, in our projects, we've had other people, nurses and social workers, other people doing this. Doctors can do it, sure, but if that's the only way you do it, you know, we were worried that you're not going to actually implement this. So we worked with them, and they did 10 pilots within Kaiser Northern California with different models, with doctors, with nurses, with social workers, inpatient, outpatient, all kinds of 10 different projects. And then they said, doctors will not be doing this. But there are other institutions that this is how they do it. We have another organization in the Northwest where the doctors are doing it, and they're doing it. Outpatient oncologists are doing it. We have another implementation project going on right now with this, which has 3 health systems, 13 oncology clinics in each of the 3 health systems, Duke, Mayo, and Northwell, 39 clinics in a stepped wedge randomized controlled trial. It's going great. The doctors are not doing it. It's being done by social workers and nurses, and it's going very well. So part of this is how to find a way to respect the organizational culture while also looking to change organizational culture. And I'm not sure why I put those pictures there. I took those pictures. I thought they were cool. So this is my youngest kid. He has a very flexible mind. This is you know, it's very important effectively when you're doing these things is to really conceptualize and try different options. Like that thing that we did in Northern California where we tried just different ways of doing it. We knew we had a thing that worked, but we needed to have it work in a new organization, in an organization that we wouldn't have so much power in. So we had to try different options. We did this also in Blue Cross Blue Shield of Hawaii. We're doing a statewide implementation with them. And there too, we had to come up with different models, different approaches, and to talk with them to conceptualize how to make it work in different types of organizations in Hawaii, nursing homes and hospitals and clinics. And we tried up a lot of different options, and effectively, they wanted to create a trained core of people to go around the state. And that's great, and eventually that'll be fine, but it's going to be like years in the making. And in the meantime, what's actually working is the nursing homes are actually having their social workers do this. This is just referring back to the doctors. It's hard to know when you're going to go to change an organization and when you're going to go to say, that's a hill I can't climb. I'm not going to succeed with that one. It's very hard to know the difference because I'm both telling you, you know, change the organization, change the culture, and I'm also telling you avoid hills that can't be climbed. Find out like how change has worked here before. How do you design? Who is going to gum up the works and how do you design to avoid them? Unfortunately, so how many doctors are there here? Okay. They won't beat me up. I'm a doctor. I often have to design away from doctors for things like this. Doctors are very important, but I often have to design. They're the hardest people to move their cheese. They are the least likely to follow a new protocol. And so things like this, you have to avoid hills that can't be climbed. So I'm going to shift gears towards the final comments because maybe leave some time for questions. We didn't really talk at all about evaluation or how to know that you're improving, but I wanted to focus a little bit more on the implementation side of this. These are different people that have funded us for the work that I was referring to. I wanted to put in a plug for the journal. So who's heard about this journal? Okay. Some hands, but not enough hands. Not enough hands. So we have a new journal. I'm the editor. We have a new journal. It's called Health Literacy Research and Practice. Does that sound like a journal that you would like your work to be published in? Oh, please, can you raise your hand a little bit? A little bit? Maybe a third of you raised their hands. Oh, this was not as successful as I was hoping. I'm not sure why someone just laughed at me over there. Okay, sexier name. No, I can't change the name. I can't change the name. We've been publishing, actually. It's now accepted into PubMed. It's going to be starting to flow into PubMed quite soon. And retroactively from the beginning, it started at the end of 2017. Everything will be in PubMed. And so, why do people publish? Why do people publish?
So other people learn.
Yeah, I used to think that, but I think that's not even true. If that were the case, then wouldn't they put in the article how to actually do their damn project? To be relevant, I think people mostly publish to make their mothers happy. I mean, that's why I publish. That's for sure. That's why I publish. No. There is a benefit to publishing, academic advancement, and to be relevant, and to tell people about your work. But really, actually, if you think that your project is done because you published it, then you really were not motivated to change the world. Because the vast majority of stuff that gets published doesn't change the world. The vast majority of the stuff that goes in the journal, that's the end of it. If you want to actually change the world, you're going to have to get involved with this implementation stuff. And you're going to have to answer the phone calls of people who say, how did that work? How can we do this? What's the next step? And so you should design stuff from the beginning that they can be implemented, that they could possibly go someplace. And then you should involve yourself in care to do stuff, or at least open the road for it to happen. So with that, thank you. We've talked about a bunch of stuff. I'd love to hear any questions you might have. Do you know what kind of animal that is? So who took the picture? Who took the picture, my son or the kangaroo? Okay. Well, anyway, so thank you very much, and have a great day.